to talk about the biological peri-implant soft tissue seal. What we should know about this topic. Okay. So if we compare between the bone implant contact on the right side versus soft tissue seal on the left side, bone implant contact is part from the history, and nowadays all the hot topic and the attention toward how we can build horizontal and vertical soft tissue act as seal and as barrier against the bacteria. So the peri-implant seal, the aim from building of this soft tissue around the implant to maintain hemostasis between the internal and the external environment. So keep the internal environment as a seal to prevent the challenges from the external environment. So not all the cases go straightforward like this case, placing single implant into the occlusion and have soft tissue, good soft tissue, horizontal and vertical. Some of cases are complicated, and when we compare between the periodontium and the peri-implant mucosa, there is huge difference regarding the number of fibroblasts, the number of the direction of collagen fiber around the tooth, the collagen fiber going perpendicular, which is preventing the bacteria from invasion, and a lot of blood vessel. If we compare the peri-implant mucosa with the periodontium, the peri-implant mucosa looks like scar tissue, a lot of collagen fiber going parallel and oblique to the implant surface. So the big dilemma to optimize the soft tissue, horizontal and vertical and the zenith, when we're placing a single implant beside the natural tooth. And this is especially in the static zone. So maintaining the soft tissue and preventing the peri-implant recession and preventing the shadow of the implant to be a problem, this is the aim of our topic today, to augment the soft tissue. So if we compare, as I said, if we compare even the biological width between the natural tooth and around the implant, in the biological width, in the junctional epithelium around the implant is longer than the natural teeth. The connective tissue seal is should be more stronger and more collagenous content. So this is called connective tissue integration. Connective tissue integration with the implant above the bone, including epithelium, which are natural teeth. This is called biological width. Okay, so this is the histology. If we see this specimen between under the microscope, comparing the peri-implant mucosa with the periodontium, as I said, in the around the teeth, the collagen fiber going perpendicular rather than going parallel. And this is actually main problem in treating cases of peri-implant recession or gingival recession around the teeth, because the problem of vascularity and decontamination, this is two main obstacles in treating such conditions. So in around the teeth, you have to do phase one, remove all of this dental plaque and improve the oral hygiene to get more healthy gingiva, which we can do soft tissue surgery later on. Around the implant, you have to remove, I think in some cases, better to graft the soft tissue in place in presence, of the prosthesis, while in other cases it's better to remove the prosthesis and let the soft tissue heal. After that, you can start from zero. Okay, this is the comparison also. So our aim from placing an implant in respect to the position, you have to place your implant in 3D position. So the position is the main key factors in placing an implant, keeping normal distance, keeping bulk of bone buccally, minimum 2 millimeters of bone should be buccally present, keeping the height, vertical soft tissue height, which called transmucosal zone, or vertical soft tissue thickness, which is minimum 3 to 4 millimeters. You have to keep distance between two implants to support the interproximal bone between the two implants, because as I said, this is main goal of our treatment, to prevent bacterial invasion and prevent peri-implantitis and maintain the crystal bone soft tissue and crystal bone for long term. So peri-implant connective tissue from 1 to 1.5, mainly collagenous, going parallel to the implant, little of fibroblast, little of blood vessels like scar, as I said. Okay, which is better, to keep the implant near from the surface without soft tissue thickness, or placing an implant in adequate depth in the bone and adequate soft tissue height to prevent the bacterial invasion and maintain the bone around the implant. So this is the concept actually introduced with Thomas in 2008. He started speaking about the biological width from 2008 and introduced concept of 0 point concept. So his concept, you have to measure the soft tissue before elevating. When you open the flap, you have to measure the thickness and the height of the soft tissue before you elevating the lingual flap. Because in some cases, when there is a deficiency in the vertical soft tissue, you have to do either placing an implant in subcrystal or doing soft tissue graft vertically. So when there is sufficient bone, you have two choices: either to flattening the bone to get more soft tissue height and more good emergency profile, or placing your implant subcrystal, either 0.5 millimeter or 1 millimeter or 2 millimeter. When there is insufficient bone, either you do tent wall technique, placing healing abutment and close the flap over the healing abutment, or doing vertical soft tissue augmentation, either with connective tissue graft or xenograft, xenograft or allograft. Placing the allograft or xenograft in the healing abutment, this is one of the options. So this is a cervical kit. There is a measurement with 2 millimeter. You have to measure the soft tissue thickness, as I said, before you elevating the lingual flap. Measure the soft tissue thickness, because this is the key if you want to placing an implant at crystal or subcrystal, and how many millimeter subcrystally. So the final result should be the soft tissue height about 4 millimeter. Okay, so the biological factors for crystal bone stability, as I said, this is not only one factor. Actually, it is multifactorial. It is related, some of factors related to the bone, some of factors related to the implant placement or implant position, and some factors related to the biology, related to the soft tissue. So the soft tissue can be divided into three factors or three categories, including the vertical soft tissue thickness, which is minimum should be 3 to 4 millimeter, and the horizontal soft tissue thickness, which is should be 3 to 4 millimeter thickness, and the keratinization that should be from a minimum 2 millimeter keratinized gingiva buccal and as well as lingual. So as we can see in this case, there's adequate depth of the implant to the bone, adequate soft tissue thickness around the implant, adequate distance, implant, good implant position, adequate keratinization buccally. All of these factors can help and maintain the peri-implant soft tissue and the peri-implant bone. Because in other cases, when we neglect these factors and neglect the soft tissue and placing an implant, this is actually the common problem with implant placement, direct implant placement or immediate implant placement. This is very common problem with the immediate implant placement, that the shadow of the implant or the shadow of the abutment is statically appear with time, because the bundle bone completely relapse and the buccal bone completely resorb. And this is one of the most common problems with immediate placement implant. So our aim, not just to build the horizontal soft tissue, as we can see in this case. There is not adequate vertical. The implant position is near from the mucosa. There is no adequate vertical soft tissue, adequate horizontal, adequate keratinization, but lack of vertical soft tissue. In other case, we have good vertical soft tissue height, but we lack to build the horizontal soft tissue and the buccal bone. So that's why the shadow of the implant is clear from the peri-implant mucosa. We have to move, I think, we have to move the keratinization from the palatal side to the buccal side, and to try to build keratinized gingiva around the implant, rather than removing the keratinization by doing a bunch technique. So better to avoid the bunch technique in such cases. So this is the necessity of attached gingiva. We have to build the keratinized gingiva around the implants, rather than placing the implant too superficial near from the surface, that will be easy for the bacteria to invade and cause peri-implantitis with time. So this is our goal, to build the soft tissue around the implant with adequate depth, adequate contour, maintaining the contour with the natural teeth. Okay. So the question, how much attached gingiva is needed or is adequate for such cases? Because in the posterior area, actually, we have very common problem in the posterior mandible. There is all the time, there's a problem with the keratinized gingiva. That's why you have to do a free gingival graft or epically displaced flap if there is adequate keratinized gingiva lingually. But in most of the cases, lack of keratinization on the lingual side as well as on the buccal side, that may cause very big problem later on with time. So to prevent the soft tissue recession and facilitate the oral hygiene measures, you have to build the keratinized soft tissue keratinization about the implant. Okay. So this is the literature, and the literature we have, as I said, sorry. Okay. In the literature, soft tissue, we have more than 2 millimeters of soft tissue thickness. As I said, this is play actually crucial role in less crystal bone resorption. As I said in the Linda, we have to, if there is a bone or mucosal thickness less than 2 millimeters, the bone resorption will start. So this is very common sentences in the soft tissue. Soft tissue is the issue, while the bone sets the tone. So insufficient keratinization also play higher prevalence of peri-implantitis, increased width of keratinized gingiva. This is our aim to reduce the peri-implant bone resorption. So what are the key factors for soft tissue graft success to build soft tissue? Actually, there is some factors related to the patient and other factors related to the site, related to the technique. This is prognostic factors by Zur and his colleagues review the many factors that you have to consider before you're doing a soft tissue graft around the implant. So first you have to determine from aim of building soft tissue, horizontal or vertical, to do peri-implant soft tissue seal, you have to determine your implant is in a static zone or in functional zone. Because some of the technique are advocated when when you are working in functional zone, and other techniques are indicated and advocated when we are working in static zone. And also there is a big, huge problem and big, huge difference between the teeth and the implant, as I said, because around the teeth, there is vascularity, the decontamination can be achievable easily, while around the implant, the decontamination, which is very difficult to decontaminate the implant as well, and very difficult to get more blood supply around from the soft tissue around the implant. So our aim, some of the cases, clinical scenarios, thickening the soft tissue of the buccal mucosa. Other factors during the second stage, you have to consider during the second stage doing soft tissue graft or the soft tissue augmentation with either with implant placement or on the second stage or later on. This is many cases of soft tissue deficiency, either around the teeth or around the implant, sometimes during the second stage, sometimes during as a complication reported after placing the prosthetic part. So the principal consideration, the second point, you have to consider our aim not to build the soft tissue in in quantity, rather than considering the quality. Nowadays, the quality is very important. Not just taking free gingival graft, placing in a static zone or in any place. You have to consider the appearance, the morphology, the chromatic texture of the integration, rather than just covering the root or increasing the amount of keratinized gingiva. So if we apply the static score toll on this case, I can consider this case a case of failure, which I did before a free gingival graft around this implant to hide the shadow of the implant. Other factors, you have to do 3D, you have to do evaluation, decision making, either to remove if there is the implant position meter and there is bone interproximal bone compromised, a lot of factors you have to consider to take the decision either to graft or to remove, better to remove those implants. Okay. The third factor you have to consider, you have to consider the gingival phenotype, which is thin phenotype or thick phenotype. This is actually main factors, because around the teeth can maintain the gingival health even with thin gingival phenotype if the patient maintains the oral hygiene. But around the implant, there is no thin gingival phenotype. All the gingiva or the peri-implant mucosa, not the gingiva. Peri-implant mucosa around the implant should be minimum 2 millimeter phenotype. That's why most of the cases, either you augment the soft tissue during the implant placement or augment the soft tissue during the second stage. And this is test doing by Giovanni Zucchelli, doing by Rossori Risprini, Julius Resperini, comparing different kinds of probes to determine the gingival phenotype, which is thin or moderate or thick. So that the fourth factor you have to consider the wound healing. Wound healing, you have to, when you're doing apically displaced flap, for example, you have to consider the vascularity and the design of the flap in respect to the soft tissue healing. You have to minimize the scar formation when we're doing any type of flap. You have to consider a magnification and the instrumentation. You need very fine needle holder, micro needle holder, very fine needle, very fine suture material, 7060 Berlin to do such a job. Okay. So I have my own kit with Divomid company, peri-implant kit and the crown lengthening kit. You can visit the website and see these kits. So what is the best technique? As I said, if you are working in a static area or you are working in functional area, this is difference. Okay. Sorry. So you have to consider also your aim is to augment the gingival thickness or your aim to improve the keratinization. That's the other factor. You have to determine you are working around a single implant or multiple implants. Anatomical considerations in the palate, anatomical considerations in the lower premolar area, on the lingual side, you have to consider all of that. The proximal bone are healthy or compromised. And the other factor is papilla shape. To do chronic, if the papilla shape is very narrow and thin, you have sometimes to remove the prosthetic part, give the chance for the papilla to grow and to thicken before you're doing your flap. And the connective tissue availability, is it available to harvest connective tissue graft or take it as from allograft. So I said different techniques we can do around the implant, either Vista technique or tunneling technique, coronally advanced flap, free gingival graft, different harvesting technique from the palate, either from Zucchelli technique or single incision, different sites from the tuberosity, from the palate. All of these factors play key for the selection of the. Okay. So let's just start with this case. As a discussion place abutment, shadow of the implant and abutment is high frenum attached to the first implant. When doing CPCT, part of the bone is resorbed, so all of this tissue, just soft tissue adhering with the implant. So one of the factors when we considering the surgery, when you are planning to do surgery, you have to keep in mind not to do a full thickness flap, either during the second stage or during free gingival graft or connective tissue graft or apical split flap or any kind of soft tissue surgery. You have to bear in mind the time of to maintain thin layer of the periosteum over the bone to give the vascularity and as a vascularized bed for the graft. So when we start with apically displaced flap, when you have your incision should be slightly palatal, doing too vertical, not too diverge, better to do it parallel or slightly converge, not compromise the placing your incision palatal, as I said, doing split, trying to maintain the periosteum over, even there is some threads of the implant or bone resorption, trying to maintain the soft tissue attachment and the connective tissue attachment, not disturb the matrix that will help in revascularization of the implant later on. And placing your implant or placing your flap, sorry, on the buccal side. This is the before and this is after. Other case, in this case, we optimize the bone, placing the implant with denser but other incision, slightly palatal, try to do some modification to build the papilla, doing palatal incision, crystal incision in some cases to be able to build a horizontal and vertical soft tissue around the implant. Cases, and on the left side, this is the red splitting case. We optimize the bone with red splitting, also optimize the soft tissue on the other side by doing apically displaced flap. Another case of red splitting, also you have to optimize the bone as well as the soft tissue. In some cases, We do a palatal pedicle flap to augment the soft tissue also, to optimize the bone, and doing apically displace flap to augment the soft tissue. This is the same case after it's splitting, placing the bone and placing apically displaced flap. In other failed cases, remove the implant, start from zero, placing the implant position, apically displaced flap to build the horizontal and vertical soft tissue to keep the peri-implant seal to prevent the resorption later on. In other cases, we are placing a free gingival graft because this is most common problem. As we can see, there is lack of keratinization on the buccal and lingual side, and there is shallow vestibule. So we do vestibuloplasty and moving part of the keratinization on the vestibule and placing free gingival graft on the buccal side and other graft on the lingual side to get such nice result. Very few cases you have to do to divide on the buccal and on the palatal side. Okay, this is very cases in the buccal. You are lucky in those cases when there is keratinization on the buccal side and also on the lingual side. Most of the cases we do either apically displaced flap if there is adequate keratinization on the lingual side, or doing pre-gingival graft, or doing as in this case you can see now the mucogingival junction where in this case we did apically displaced flap. Your incision should be on the palatal side, doing split thickness, move this keratinization, and suture it buccally. Also, this case, another case of apically displaced flap, moving the keratinization from the buccal side to the palatal, from the palatal side to the buccal side to get such nice results. Okay. Other cases we use also Autotooth Smart Dentine graft to augment the bone during the implant placement, and using cervical kit during the second stage to get such nice result of building the soft tissue in height and in depth, and adequate keratinization, which act as peri-implant soft tissue seal. In other cases, you do a rule technique. In other cases, we are placing a connective tissue the buccal soft tissue during placement, while in other cases we're correcting the soft tissue during the second stage, either with placing a connective tissue graft or roll technique or apically displaced flap or free gingival graft. In other tissue after prosthetic part, we have to remove the prosthesis, give the chance for the papilla to grow interproximal to be able to do coronally advanced flap or tunneling technique. This is another case. We didn't remove the prosthesis because the bridge, longer bridge, I didn't remove the prosthesis. I'm placing the connective tissue over the bed, decontaminate the implant also before placing the graft, and this is the result after 3 months. So we consider that the connective tissue graft is the best protection to the bone. Also, it is the best protection for the implant. In some cases, we have to do horizontal augmentation. In other cases, we have to do horizontal and vertical augmentation to get peri-implant soft tissue seal. In this case, I did a connective tissue graft to get a horizontal soft tissue width. And where is the site? Where is the best place for harvesting a connective tissue graft, either from the palate or from the tuberosity? Actually, it depends the amount of the thickness you are. If you are target more than 1.5 millimeter thickness or more than 1 millimeter thickness, it is better to harvest your graft from the tuberosity area, because the tuberosity can give you thick graft, more collagenous, more stable or long term. But if your target is about 1 millimeter, 1.2 millimeter, either to harvest the graft from the posterior palate or from the premolar area. I like to harvest the graft from the posterior palate as Zucchelli technique. And this is comparative study. Zur and his colleague Marcus comparing between 4 sites, and they found there is no significant difference. But other studies doing by Peter comparing between the tuberosity and between the premolar area, they found that tuberosity is more stable and better option than the soft tissue from the and this is Another summarize that the deepthalized gingival graft may be considered as a Zucchelli technique, because in the Zucchelli technique, if you're going too posterior and at the molar area, the connective tissue layer would increase and this reticular layer opposite to the premolar area. And this is the technique. So the harvesting technique, better to go to the molar area, doing your incision first perpendicular. After that, you have to go parallel to the palate, harvesting uniform, okay, uniform thickness of the free and connective tissue graft, and deepthalize this graft outside the patient's mouth. So first incision should be horizontal on the palate, perpendicular. The other one should be parallel to the palate. Keep it parallel to the palate, rested on the bone to get same uniform thickness at the posterior bar for hemostasis and cross sutures over the graft. Okay, because in some cases the thickening is our target, in other cases the anchoring is our target, in other cases protection is our target. So every case is completely different. In this case, recession, severe recession, this target is to protecting the bone. We're placing a free gingival graft around these teeth. It is not hopeless, actually. There is no slight mobility around the teeth, so we can augment the soft tissue and improve the patient oral hygiene by improving the keratinization around those implants, or doing coronary space flap around the other cases. So this is the harvesting technique. Start with distal incision. After that, going perpendicular to the palate, parallel to the palate to harvest uniform thickness of free gingival graft, harvested out the patient mouth to get a uniform thickness of connective tissue graft. Okay, either placing or stent or placing cross sutures. This is how to control the bleeding and minimize the discomfort for the patient. So our target to optimize the implant site for long-term success with soft tissue graft, and consider in respect to the implant position and the bone around the implant. Okay, many cases. So there is a classification by Zucchelli for the peri-implant soft tissue dehiscence or recession, either at single implant site. He divided the recession to 4 types. So I can summarize now the technique. When we working around the teeth, the blood supply is better and the chance for decontamination of the root is easier. Around the implant, the blood supply is compromised. Sometimes you have to remove the prosthetic part. Sometimes you have to make a very narrow neck of the prosthetic part to give a chance for the interdental papilla to build and to grow, to be able to do coronally advanced flap. And the chance of decontamination is difficult. There is no universal protocol for the contamination of the implant. So this is the last question, which is the best technique if you want to build the soft tissue around the implant, either to do implant decoronation, this technique described by Tarnow in 2013, to remove the prosthetic part, placing the implant cover screw, and give the chance for the soft tissue to heal. After that, start from zero, or either to do coronally advanced flap if there is adequate interdental papilla thickness and height, interproximal bone is intact, or doing a vista technique or tunneling technique of placing connective tissue graft from the vestibule or through the tunnel, or placing a free gingival graft in the posterior. This is the only consideration and the only indication for the free gingival graft to placing, consider to placing a free gingival graft only in the posterior mandible and functional area. So this is the first technique, decoronation, described by Dennis Turnow in 2013. I did one case of implant decoronation, remove the implant, placing Maryland bridge, and you can see the result of the soft tissue integration and soft tissue migration creeping just after 1 week. You can see now we get about 1.5 millimeter. The papilla is still growing on this part, still growing on the other side. The gap is completely closed, but still we have some shadow. Now we can start from zero, either doing tunneling technique, vista technique to improve to improve the thickness and hiding the shadow. Actually, in this case, I did a vista technique, incision through the frenum, and introduce the graft just through the frenum with a small incision, just with one suture, small incision, and placing the graft from the frenum, from the vestibule, to hide the discoloration. While in other cases, as around the teeth, you have to work first non-surgically, prosthetically, to remove this crown, remove this pink porcelain, give the chance for the gingiva to migrate and creep. After that, you can do coronally advanced flap. As in this case, there's a very deep implant position, a lot of pink porcelain, statically unacceptable after 7 years. This is history of 7 years, and this is the CBCT. There is no bone resorption. The bone is good around the implant, but the implant is placed too deep with shoulder is slightly buccal. Patient has a slow smile line, but patient want to do a soft tissue graft. He's a dentist actually, and he want to do a soft tissue graft around this implant. So I prepare the case pre-surgically to do prosthetic part. After that, doing I did actually coronally advanced flap by doing the first incision perpendicular at the base of the interdental papilla with microblade. After that, change your direction to do a beveled vertical exceeding the mucogingival junction with 2 to 3 millimeter, connecting the two incisions. All of these incisions are superficial, not contacting the bone. Okay. After that, change your direction slightly parallel, going parallel to the mucosa to do split thickness papilla. This is the key for coronally advanced flap. You have to split the interdental papilla. This is the surgical papilla. You have to keep epithelium with some connective tissue in the flap to be able to be advanced and to give stability for the flap after depithelize the anatomical papilla. Also try to do split thickness over the implant to keep the connective tissue attachment over the implant and not disturbing the matrix. So this is the key. You have to split the papilla in two parts, surgical and anatomical, and try to split the other flap in uniform thickness and maintaining the adequate part of keratinized gingiva in the flap. So this is the second part. After elevating the flap, you have to keep some part of the periosteum, over the implant, not disturbing, not exposing the implant threads, and try to move your flap coronally without any tension. This is the second factor you have to consider during coronal advanced flap. After that, going to the tuberosity, harvesting very small part from the posterior and tuberosity part of the palate. Keep it folded to give the thickness and advance the flap over. This is the immediate result in the lateral view, and this is 1 week after, and this is 2 weeks. This is still not mature soft tissue, but we get the same zenith with the natural teeth. There is a little of scar. We were waiting for more soft tissue maturation with time. Okay, this is the preoperative, and this is the immediate postoperative, and this is 2 months later. And Zucchelli, actually, Professor Zucchelli has 5 years outcome after root coverage with coronary advanced flap with prospective cohort study. So finally, take home message. Our aim from this lecture to emphasize that the importance of the soft tissue around the implant, you have to have good attached gingival mucosa and vertical soft tissue to maintaining the crystal bone stability. At least 2 millimeter of bone, at least of attached gingiva, is needed on the buccal side as well as on the lingual side. And in some cases, you have to consider to harvest a connective tissue graft as well as porcine derived xenograft or allograft used to establish the peri-implant immobile peri-implant mucosa around the implants. So this is our take-home message to augment the soft tissue, respect the vertical and the horizontal with the respect of the keratinization at least of 2 millimeter on the buccal and on the palatal side to maintain the soft tissue seal around the implant and maintain the crystal bone stability. Our teamwork is our target to be. There is a lot of this is not not my work. A lot of my colleagues working with me either in Al Hussein Clinic or in Al Andus Clinic or in Asnana Clinic or in Salam Clinic. I'm working in many clinics in Tripoli, in Coms, in Musrata. Finally, I would like to thank you, Professor, and I'd like to Dr. Ali on this kind invitation, giving me the chance to present my simple work, short experience with you. Thank you. Thank you very much.